Hello, my name is Kareem Salhiya. I'm a consultant cardiothoracic surgeon. We're going to talk today about prosthetic heart valves and help the patient in making the decision for the right choice for them. When heart valve get diseased, there is a need for an operation to either repair or replace those valves. Mitral and tricuspid valves are more likely to be repaired than aortic valve, which more likely to be replaced. When we replace heart valves, we use prosthetic heart valves, and these valves are used in replacement for the native valves. What are the type of valves that are available for replacing heart valves? There are three types available in the market at the moment: the metal one, or the mechanical valves, the biological valves or the tissue valves, and human valves or homografts. Now, what are the differences between these valves? The mechanical valves are totally man-made. They are made of complex carbon sheets of high quality and purity, made into two leaflets that open and close. These valves have the advantage that they can last for the patient's lifelong, but on the other side they require a blood thinning medication or anticoagulation for them to work properly. The other downside of these valves is they have some sort of a clicking sound that can be heard by the patient in a quiet room, especially at night. Most of the patients find this is okay with them and they adapt to this fairly quickly. Very small percentage of patients find this irritable and irritating, but most of the patients, they appear to adapt with this noise. The tissue valves are valves made from animal tissues, biological tissues, and they can be made from cow tissues or pig tissue. The pig valves are made from the actual valve of the pig, while the bovine, the cow ones, they are made from the lining of the heart of the cow heart, made into leaflets, and they're made into three parts. The big advantage of those valves is that they avoid the use of the blood thinning medication, what we call it warfarin. But unfortunately, because they are biological tissues, they are susceptible for wear and tear and calcification, and they don't last forever. They expect it to last somewhere between 10 to 20 years before the need for replacing them again. With the new technologies in valve manufacturing, those valves are expected to last longer than before due to improvement in the technology and adding the anti-calcification material that reduces the incidence of wear and tear. There's a new valve in the market that's been released recently that has been made on a new technology, and this one is expected to last, based on animal studies, for more than 20 years, and this is very promising. The third part is human valves, or what we call them homografts, and these are taken from donor human hearts, people who donated their hearts, and the valves are taken and they be used for replacement. However, due to the scarcity of resources and the number of donor hearts, these valves are not available commonly, and they are reserved to be used in complex operations such as Ross procedure and operations involving the aortic root and infection of the heart. Now, which is better, mechanical valves or tissue valves? There is no perfect valve. Every valve has its pros and cons, and the decision for choosing one or other depends on many factors, and it's a patient's decision at the end. The factors that affect the choice of heart valve include patient age, the position where the valve needs to be replaced, whether aortic or mitral. In ladies who would like to have children, and if there are any conditions or diseases that are contraindicated to use blood thinning medications, and finally patient career and lifestyle, especially dangerous sports. Now, in summary, the differences between metal valves and tissue valves is that metal valves, they tend to last forever in over 89% of the patients. This will be at the price of taking blood thinning medication regularly. On the other side, tissue valves avoids the need for blood thinning medications at the cost of a wear and tear and the need for further replacement or re-intervention 10 to 20 years later. Now, what is the problem of taking a blood thinning medication? Blood thinning medications are generally safe drugs and are commonly used. It is estimated that about 2 million people in the UK, they take blood thinning medication, especially warfarin, every year. However, there are certain precautions that has to be taken into consideration. First one, that when we use a metal valve, and especially taking warfarin, the medication must be taken regularly without stopping it for any reason unless under medical supervision, because stopping the medication puts the valve at a risk of clotting, and this is a very dangerous thing. The dose for the medication needs to be adjusted regularly based on a blood test. So patients must undergo frequent blood testing to control the dosage regularly, because if the blood becomes too thin, there is a risk of bleeding. And warfarin adds to the risk of bleeding about 1 in 1,000 per year per patient, especially in the elderly. This risk increases with accidents and with sports injuries and dangerous sports. Finally, warfarin is not suitable for pregnant women because it affects fetuses, and therefore pregnant women or women who would like to have further children will have to undergo special treatment. Now, when is it recommended to use a mechanical or a metal valve? International heart societies and associations recommend the use of metal valves in younger people, and this is less than 60 years of age in patients who are having an aortic valve replacement, and less than 65 years of age for people having a mitral valve replacement. And the reason for that is having a tissue valve replaced at a younger age puts the patient at risk of requiring 1 or more operations for re-replacement of those valves. Previous studies have shown that putting a mechanical valve in the younger population is associated with a better survival and a long-term outcome. On the other side, when is it recommended to use a tissue valve? A tissue valve is recommended to be used in the older age group, which is more than 60 for the aortic valve and more than 65 to 70 in the mitral valve. Also, it is recommended for those tissue valves to be used for ladies wishing to have further children, any patients who will have a problem or a contraindication for having a blood thinning medication, such as warfarin. And generally speaking, we reserve the use of tissue valve for the right side valves of the heart, which is the tricuspid and the pulmonary valve, because of less pressure, they last for a long period of time. What is the durability or the life expectancy of a tissue valve? The life expectancy or durability of a tissue valve depends on different factors. Number one, it depends on the patient age. So the younger the patient, the more likely the valve will get wear and tear and calcification at an earlier stage. This is due to pressure differences in young people and the force of contractility of their heart muscle compared to older population. So for example, if a patient gets a tissue valve at the age of 40, it is expected to last a lot less than a patient at 70 or 80. The other thing is the position of the valve that we use it for. As we mentioned before, tissue valves put in the mitral position are more likely to wear and tear, again because of the pressure changes within the heart. Of course, there are differences between the brands and types available in the market, and some brands have a better long-term durability than others. And the last thing, of course, is there are patient factors. There are patients who are more susceptible to have premature degeneration or wear and tear of their valves. Unfortunately, there is no way that we can predict which patient is going to have a quicker and accelerated degeneration than others. So what happens if there is calcification or degeneration for a prosthetic tissue valve? Generally speaking, this happens over many years. It's a gradual process, and usually the patient is kept under close follow-up by the surgeon and the cardiologist. When this diseased valve reaches a significant point, there is a need for an intervention, and usually this is through replacement of the valve. Now, with the new percutaneous technology, which is the new valves put through the catheter called the TAVI valves, this has given a lot of hope for those patients to have a less invasive procedure, and a valve can be placed inside the previous diseased valve and give a perfect function. The availability of this technology has encouraged lots of younger people to choose the tissue valve with the hope that in the future they can have a minimally invasive TAVI valve inside. However, it must be kept in mind for all the patients that this decision will be reserved for the time the valve degenerates, because simply by the time they need their valve to be replaced, their condition might not be suitable for a TAVI valve. And this is a small but a significant risk to be taken in mind, and therefore they might still come back for an open heart redo surgery. Can the mechanical valve get disease or calcification? Yes, it can. Like we said, there's a 2% chance that in the patient's life there will be a problem with the mechanical valve. They can grow some calcification, or we call them panas, and they can obstruct the movement and have to be replaced. So in 2% of the people, they can have this condition, and also sometimes these valves can get infected and they will have to get replaced in this case. What is the future for heart valve therapy? We are all currently working on developing what we call new tissue engineer heart valves, and these valves are made into scaffolds of different biological material, where we can implant certain cells on top of them, and especially stem cells. We expect these cells to behave pretty much like the normal valve, where they can grow, they can repair themselves, and they can adapt. And hopefully these valves will overcome the problems that we see in both the mechanical and the tissue valve, and we will be calling them the living valve. Finally, our advice to the patient is that there is no perfect choice of the valve, but it is their full right to be aware of the benefits and complications of these valves, the pros and the cons. And it's our responsibility as heart surgeons and heart specialists to explain to the patients these factors in details, so the patient will be fully informed and they will take their full informed decision for what suits their choices in life and their lifestyle. And finally, we wish everything well and happiness.